Today's talk is going to be about pediatric syncope and addressed from the cardiologist perspective, which is, as we all know, the most important perspective. The reason I decided to do this talk was typically syncope is usually our number 3 diagnosis in our clinic. And now I typically have at least 2 or 3 patients per day referred to the clinic. Previously, we would get referrals for things like true syncope or concerns for exertional syncope, and now we're getting referrals for things like orthostatic dizziness or positional dizziness, and the line has moved back, I think, out of caution for folks worried about the possibility of worse etiologies or worse symptoms. So I neglected to put there you go, already not working. A disclaimer slide. I don't have anything to disclose, so much so I didn't put the slide in. The objectives for today's talk are basically to define syncope, review the incidence of predisposing factors for syncope in children and adolescents. We're going to review common etiologies, although we're going to limit it mostly to neurally mediated syncope and cardiac causes. The evaluation, and then possible treatments to prevent further recurrence. So the definition of syncope, you start with one sentence, then you keep having to add caveats to what it means. But it's a sudden and transient loss of consciousness and postural tone due to reversible impairment of cognitive function from cerebral hypoperfusion, obviously not requiring electrical or chemical cardioversion for recovery, and then typically excluding known seizure disorder or traumas that might have induced the unconsciousness. During the first 2 decades of life, it's fairly common in children and adolescents with a lifetime incidence of up to 50%. The incidence for pediatrics varies by age. We typically have 2 peaks that we see in our clinic. The first is preschool age, which overall comprises 2.7%. That are usually related to breath holding spells. That 8.3% in school age, I don't see very often, although I am seeing one today. But primarily where we're seeing patients is our adolescent patients, where 29% of those folks are going to have a syncopal episode with a higher preponderance in females than males. If there is one episode, there's a fairly high recurrence rate of 1 in 4. And overall, the syncope accounts for 1% of or pediatric ER visits. This is a study of 4,300 children. Now, this was a recall survey asking patients about their symptoms, and we see a pretty big spike here in adolescents. They were getting an incidence, within the 30 to 40% range for a lot of these adolescents, and that has been consistent. So this is 2021. This is the sort of the initial pediatric syncope study by Driscoll from '97, where he looked at all the hospitals around the Mayo Clinic in Rochester and went through all their medical records, both in 1950 and again in 1990. And we see that same rise here. It's kind of interesting that the incidence of male syncope is higher than in 1950, and then vice versa for the female population. So why do we go to all the trouble? The first thing is cost. We talk about resources taking up about 1% of pediatric ER visits. A couple of cost evaluation studies. The first one I have on here is from 2005, looked at 170 patients evaluated. Total cost of that evaluation was $180,000, so just over $1,000 per patient. And then more recently at Cincinnati Children's, where $1.1 million was spent to evaluate just over 440 patients with an average charge of almost $2,500. Within that particular study, about 45 to 50% of the testing had been done prior to the cardiology visit. Obviously, there's a cost in terms of schoolwork absence, but also the social cost of schoolwork absence, and we'll talk about that on the next slide. For us, obviously, the cause of syncope may be an early warning sign for sudden cardiac death. Driscoll also published a paper in '85, said that 20% of athletes with sudden cardiac death have at least one prior episode of syncope as a potential warning sign. Neurally mediated syncope, we typically classify as benign, but if you're fainting while you're on the back of a horse, while you're juggling chainsaws or something else the kids are doing that's crazy these days, obviously you can hurt yourself if you pass out during that time. And then just the anxiety of having the initial or subsequent episodes leading to anxiety with school absence, lack of desire to participate in sports and social activities with overall reduced quality of life. So this is a PEDS-QL scale from 2016, and you'll notice that if we look at, say, diabetes here, that the quality of life is actually lower for syncope than it is in diabetes in terms of emotional functioning. Psychosocial health, you have that same imbalance as well. So it's a pretty impressive decrease in quality of life related to more chronic diseases. So we typically break down the etiology of pediatric syncope into more or less three areas. The first one is neurally mediated, which is obviously the most the highest incidence of syncope. The first one would be reflex syncope or vasovagal syncope, and breath holding spells are sort of included in that. Disorders of orthostatic intolerance, that it would include POTS, cardiac abnormalities, which is obviously why they're being sent to us, and then non-cardiac, including neurologic, metabolic, psychiatric etiologies. And even with that, in a lot of ER assessments, up to 18-19% of the cases don't come out with a confirmed diagnosis as to the cause of the syncope. A lot of it can be assumed, but if it was an unwitnessed episode, if the patient has amnesia of the event, it's really hard to kind of piece that together and give it an etiology. So this is that same Chinese study with the 4,300 patients. We see that autonomically mediated syncope comprised about 73%, with a breakdown of 43 for vasovagal and 27 for POTS. Interestingly, orthostatic hypotension actually had a very low incidence of only 1.3% in the population. And we'll see later that true orthostatic hypotension, just chronic orthostatic hypotension, is pretty unusual in the pediatric population. In terms of cardiac causes, not quite 3% total, so a pretty low incidence. And then again, 19% in this particular study that did not find a known cause. So, cardiac syncope, we said numbers as low as 2% up to 6%. Important for us because these may represent aborted episodes of sudden cardiac death, or in patients that have known outflow tract obstruction, it may indicate a worsening of disease. Characteristics of the fainting episode that are more unique to cardiac syncope would be sudden loss of consciousness in the midst or during exercise, whereas syncope after the completion of exercise, when the vessels in the extremities and the skin are vasodilated, is typically vasovagal in etiology. A true lack of prodrome symptoms going into it. In one study from 2017, you had 85% of children with a known prodrome as opposed to 40% of cardiac syncope patients. Syncope while supine, also an unusual thing. We typically associate that with neurologic or psychologic issues, but it certainly could be cardiac in origin, particularly if it's a dysrhythmia. And in keeping with that, palpitations prior to syncope may represent a dysrhythmia. In terms of our physical findings, those are often going to correlate with an abnormal cardiac physical exam. And then obviously an abnormal screening ECG can give you clues to that to the etiology. Screening for family history is also important for family members with primary dysrhythmias, known channelopathies, early onset cardiac disease or sudden cardiac death, or even just family history of deaths that were highly questionable, like a good swimmer who drowned, single car accidents with no known cause could be indicative of some dysrhythmia in a family member. So the typical breakdown here, usually when we're seeing patients in clinic and we're talking about potential cardiac problems, I break it down to structural, functional, and electrical. And really, you can't have anything outside of that. With hypertrophic cardiomyopathy, again, syncope in the midst of exercise. Congenital heart disease, they're going to have an abnormal cardiac exam. They also have the helpful finding of a mid-sternotomy incision, which is always a good sign to help point you in the direction of cardiac syncope. Most cardiomyopathies are going to have signs and symptoms of heart failure, and then we'll talk about the dysrhythmias here in the next few slides. So this is kind of the, we're seeing somebody in the emergency room with syncope during exertion. This is the ECG that you don't want to see, because this implies you're going to be pulling this young athlete out of sports altogether. So we see very prominent R waves in V5 and V6, and big prominent S waves in V1, indicative of left ventricular hypertrophy. And then we see a T wave inversion in the inferior and the lateral leads, which is indicative of a strain pattern. And that's typically what we're going to see in a hypertrophic cardiomyopathy. And that is a big concern. And the most common cause of sudden cardiac death in athletes in the US, as opposed to ARVD in Europe, which we'll talk about later on. This particular diagnosis kind of rose to prominence after Hank Gathers, who was a NCAA basketball player for Loyola, had died in 1990 in the midst of a basketball tournament. It really kind of shed a light on these problems, and a lot of the research moving forward after that were prompted by that event. So in terms of structural causes, we talked about left-sided outflow tract obstruction. In the setting of activity, we're going to see syncope because of not just outflow tract obstruction, which may be fixed or dynamic, but also significant peripheral vasodilation in the muscles and in the skin vessels, which are dilated to expend heat to the environment. In that setting, you also have increased myocardial oxygen demand with decreased oxygen delivery. So that's, aside from just the outflow tract obstruction, now you're increasing the risk for ischemia of the heart muscle due to oxygen demand, and that's going to increase your risk for dysrhythmia during activity or shortly afterwards in the recovery phase. So in hypertrophic obstructive cardiomyopathy, up to 50% may have a family history of diagnosis. Many of the mutations are autosomal dominant. In the physical exam for these individuals, these kids have a murmur that gets louder with upright posture and gets quieter when you squat them down. And then a fixed obstruction, say in aortic valve stenosis, that's a murmur you're going to hear when they're lying, sitting, standing. But again, it's going to get louder when they stand up because you're decreasing afterload. And so the functional gradient across the aortic valve gets worse. Having you develop syncope with exertion may indicate that outflow tract obstruction is progressing. And then on exam, aside from the murmur, you're going to have potentially an ejection click and increased precordial activity with an LV heave. Outflow tract obstruction on the right side is fairly uncommon, but pulmonary hypertension or Eisenmenger's physiology, either in unrepaired intracardiac shunts or primary pulmonary hypertension, is a form of right ventricular outflow tract obstruction in the sense that there's pulmonary venous obstruction, functional pulmonary venous obstruction because of reduced cardiac resulting in reduced cardiac output. And that's because the blood, due to a high transpulmonary gradient, just can't get through the lungs to get around to the left side to get out to the body. Aside from that, coronary artery abnormalities and anomalous left coronary. In the majority of cases, an anomalous left coronary is going to be picked up in infancy with a pretty sick infant. But if you have just enough support from the right-sided coronary, over time you have enough bridging over to the left that those patients sometimes fail to be detected and can get through, in rare cases, entire sports careers without having anything. So in this case, you know, if you stress beyond the ability for the oxygen delivery to meet demand, you're going to develop ischemia. You may see signs of dysfunction. This is going to be less syncope. There may be angina and chest pain going into the episode, and of course, an abnormal baseline ECG. And the most common, or the most, I think, popular story related to this is Pistol Pete Maravich, who was a basketball player who died in the late 80s playing a pickup game after he'd retired due to a late diagnosis of an anomalous coronary. I also found out that one of the Partridge Family kids had this diagnosis, and it's how she died. It was the one that played the tambourine. So there may be an association with tambourine. With Kawasaki disease, history of aneurysm formation. Again, some, Kawasaki disease goes undiagnosed. I think we're pretty good at picking up a lot of prolonged fevers, but in atypical Kawasaki's, particularly in kids below 6 months of age or older than 5 years of age, we may miss this diagnosis and come to find that there's aneurysms in middle school and high school because we're developing thrombus formation in those abnormal coronaries. Dilated cardiomyopathy is going to have a less common family history. You can see it in neuromuscular disease, anthracycline toxicity in our late effects chemo patients. Healed myocarditis with residual cardiomyopathy. We see that in COVID-19 in adults, but we really haven't seen that same issue with pediatric patients. Lyme carditis can give you a transient myocarditis that can result in a cardiomyopathy. These kids, though, they're going to have a lot of exertional symptoms. They're going to have, dizziness and syncope, occasional chest pain. They're going to have poor exercise tolerance that's progressive and getting worse. If they do pass out with activity, that can be concerning because aside from the function issue, you may have developed a ventricular dysrhythmia. And the exam for this is going to basically look like a guy who's in heart failure. From a tachyarrhythmia standpoint, starting with SVT, obviously Wolff-Parkinson-White, orthodromic versus antidromic. So orthodromic is anterior conduction while in SVT through the normal AV nodal pathway. If you have antidromic conduction, that means that the conduction is capable of going fast through that accessory pathway. Those are higher risk Wolff patients because they can rapidly conduct SVT that can, if that degrades to AFib, that can then result in VFib being rapidly conducted down the accessory pathway. In teenagers, though, AV-NRT is much more common. That's much more well tolerated and has a much lower sudden cardiac death risk. Ventricular tachycardia, we have channelopathies, long QT syndrome, short QT syndrome, Brugada, and then CPVT. And again, we talked about those unusual syncopal episodes of being a good swimmer who passed out, passing out while sitting or driving or something like that. Arrhythmogenic right ventricular dysplasia, which is a type of cardiomyopathy, but is the most common cause of sudden cardiac death in European athletes. Myocarditis is more prone to ventricular tachyarrhythmias, as are drug and toxin exposures, and then a past history of congenital heart surgery. So bradyarrhythmias like sinus node dysfunction, typically those kids will have had a past history of cardiac surgery or left atrial isomerism and heterotaxy because they have basically two left atria and no right atria, so there may not be a fixed sinus node. AV block is usually, if it's acquired from an inflammatory or infectious process, we can see it with drug toxicity such as digoxin. And then we have congenital causes like congenitally corrected transposition, where 25% of those patients may present with AV block. Neonatal lupus technically isn't congenital heart block, but 1 to 2% of babies born to moms with lupus or Sjogren's disease with positive SSA and SSB antibodies can develop congenital heart block and often require pacing during childhood. So here's our Wolff-Parkinson-White pattern here with clear pre-excitation with a short PR interval. Again, this pattern in and of itself doesn't mean that this was the cause of the syncope in a given patient. With Wolff-Parkinson-White, it's not a question of if they're going to develop SVT, it's just a question of when. And so, at least in our pediatric patients, we typically recommend that they go ahead and have an ablation. So here we have, looking at our rhythm strip across the bottom, we see P waves sort of marching through. And so this would be third degree AV block with an atrial rate of around 100 with a ventricular rate of 55. Now, if this is a teenager, maybe 55 would make the number red in the chart, but let's say it was 60 beats per minute, and that would be this junctional rate. That may not be flagged in the electronic record because the number isn't red. And so looking at how a patient presents, say with fever, trauma, or infection, And if they have a low resting heart rate that doesn't fit, you may want to look at an ECG to assess for this. Now, this looks a lot like the previous one because we see P waves marching through and then our QRS complexes. But this is actually a much more worrisome problem. This is long QT syndrome with 2-to-1 AV block. And so a patient in this situation is much more at risk for an R on T phenomenon and developing torsade and sudden death. The reason we like to get ECGs on these patients, but why it may not be helpful, is that about 15% of kids with long QT syndrome may not have prolongation of the QT interval. They may come in and show you a relatively normal number. So back 10, 15 years ago, we might have used a cutoff of 440 and 450 in males and females, and now we're typically using 470 and 480. So as we talked about before, neurally mediated syncope comprises, at least in that Chinese study, about 43.5 of the syncopal episodes, with classic orthostatic hypotension being around 1% and POTS being 27%. The typical response to standing is initially you have up to a liter of blood pooling in the lower extremities in splanchnic circulation. So standing up, you have decreased systemic venous return initially. So that's going to result in low preload volumes and low cardiac output. That decreased stretch of the baroreceptors and C fibers, the C fibers in the atria and the ventricles, are going to cause a decreased afferent input to the brainstem. So that's going to allow for increased sympathetic output and decreased parasympathetic output, resulting in increased heart rate and vasoconstriction. And that really ought to occur within a minute or so, such that after 3 minutes of standing, your heart rate and blood pressure should be very close to what they were when you were sitting or lying down. So vasovagal syncope is called a simple faint, reflex syncope, or situational syncope, and we'll see a graph for that here in a minute. Most common form, the Canadian definition, is only after 30 seconds of standing, but I was taught that the postural form is typically after 3 minutes of upright posture. More common in females and strongly associated with prodromal symptoms as listed here. Not typically associated with primary cardiac symptoms like palpitations and chest pain. Medical conditions that increase the risk are things that make sense: anemia, thyroid problems, dehydration, infection, pregnancy. Female patients often will report an increase in the frequency of symptoms in the week or so prior to menses. Also, we see it with acute weight reduction and crash diets, and then during big growth spurts during puberty. Situational ones would be, environmental ones would be warm environments, close situations like elevators or church, decreased PO intake, prolonged bed rests, and then in post-exertional syncope, we talked about vasodilation, both in the extremities and the muscle, skeletal muscle, and in the skin. In terms of situational syncope, we see there's a pretty strong micturition, also associated with defecation here. Bathing, we see a lot of shower fainters. Swallowing, coughing, singing. In this particular study was 350 patients with an average age of 16. These patients, interestingly, men were more likely to faint with peeing and coughing and after eating, whereas women were more likely to pass out with bathing, swallowing, singing, and toothbrushing and hair grooming. So the etiology for vasovagal syncope is, first of all, adolescents typically have increased autonomic tone compared to adults, have venous pooling like we typically have in prolonged standing. And that's this activation of the C fibers, just like we talked about in standing, that low volume is supposed to trigger those to increase sympathetic tone. And that happens, but if that filling volume doesn't get back to the ventricles because you haven't moved around or you haven't had enough to drink or you're dehydrated, that hypercontractile response of the ventricles against an empty ventricle will cause a paradoxical sympathetic activation followed by immediate vagal efference. And so a drop in heart rate and a drop in blood pressure. And so you can have a primary vasodepressor response with a drop in blood pressure of 50 millimeters of mercury, or a cardioinhibitory response with a heart rate drop of 40, or a systole of over 3 seconds, although the EP guy, UVA, has seen a systole of over 20 seconds in some individuals. The majority of teenagers, though, will have a mixed type. Vasovagal syncope is typically going to have a short duration of loss of consciousness, less than 2 minutes, don't require resuscitation. You can have urinary incontinence, and 10% may have some myoclonic movements that look like a seizure. The way to contrast those two is that the myoclonic movements typically occur with the onset of symptoms in a seizure, whereas they occur after loss of consciousness in neurally mediated syncope. Patients awaken with confusion and maybe sluggish or fatigue for minutes or hours after the event, which can often be confused with being post-ictal, and getting them up too quickly may cause a second event. The evaluation is typically taking a good history and reviewing the symptoms in the setting of the syncope. Prodromal symptoms, like we said, are strongly suggestive of vasovagal syncope. It's helpful if you've had people that saw it. And then if your family history is negative for anything. You can do postural vital signs at the time. They're really only helpful for how you are right then. So hydration status, if you're looking for disorders of orthostatic intolerance like persistent orthostatic hypotension or POTS, those vital signs are going to be abnormal after 5 minutes of standing. Initial evaluations at 1 minute aren't very helpful. And like we said, with the normal standing response, they should be back at those baseline numbers within 3 to 5 minutes of standing. Obviously, we want to do the cardiac exam to look for those abnormalities that we discussed on the previous slides. Lab work is typically not useful, although a lot of EMTs do glucose checks on these kids coming in. If there is a concern for cardiac syncope, an ECG may be indicated. If they had a cardiac etiology, a combination of history exam and ECG had a 96% sensitivity, but a low yield of less than 1% for all the total population with a fairly low specificity. We always get questions about tilt studies. The majority of pediatric centers don't do them, including CHOP and Cincinnati Children's. Part of it is there really isn't a standardized protocol for this. There is a low sensitivity and specificity with a pretty poor reproducibility of only around 50%. You can get 60% of normal kids to faint on a tilt study who have no prior history of syncope. And if you really want to do something similar, the bedside active standing test is less invasive and also equally validated. So this is a flow sheet that you guys we can get. You can get a copy of the talk with an algorithm looking for basically the similar things we talked about previously. And again, if you get all the way down here, if it's consistent with vasovagal syncope, no real further investigation is required. And we'll talk about the treatment strategies. So the most common thing is reassurance. If they have the symptoms, have them sit or lie back down, counter pressure maneuvers, and we've got some cool images of those here in a minute. Increased salt and daily hydration. So typically, a number of the papers will set goals of 100 ounces or 3 liters. I typically begin with a minimum of 2 liters of water a day. You can use sports drinks, but primarily it's important that they pre-hydrate before sports, since we see a lot of symptoms then. Avoidance of caffeine because of the diuretic effect, and then increased daily sodium intake with a minimum of 2 grams a day, although I typically recommend 4 grams a day. Wall standing, which has been shown to show significant improvement with lack of recurrence of syncope. Basically standing with your back against the wall with no arm or leg movement for 5 minutes to start, and over the next 6 to 8 weeks, slowly increasing that to 30 to 40-minute intervals, and then increased routine aerobic exercise. First of all, that's going to improve muscle tone in the lower extremities, and that will improve systemic venous return. And then just doing the exercises increases circulating blood volume. Here's some cool pictures of this guy. These are all poses I probably took from my 7th grade school pictures, and I didn't know that I was doing counter pressure maneuvers to prevent fainting. So pharmacotherapy, fludrocortisone, we often use it as a first-line medication. It is a mineralocorticoid. It's basically antidiuretic hormone, increases circulating blood volume through sodium and fluid retention. Unfortunately, it's shown to be ineffective in pediatric patients as well as adults in a randomized control study. And in fact, the use of placebo had better outcome in pediatric patients. And the thing about that study that's interesting is that the placebo pills were orange and green, and the medication pills were white. And the thinking was, well, these pills are colored, so they must be doing something. That's why I think they're working. Beta blockers have shown not to be effective for patients in vasovagal syncope. They've been removed from the European guidelines. And then midodrine, which is the only medication that has shown positive improvement in symptoms. It's an alpha agonist causing peripheral vasoconstriction. Doesn't cross the blood-brain barrier, so it doesn't treat quote-unquote brain fog, and it does not cause hypertension. But in terms of recurrence rates in a subset of patients with controls having recurrence of 80%, these patients, the recurrence was down to 22%. SSRIs are often recommended as a fourth tier, but there's no randomized controlled trial for this. Although if the patients have a lot of anxiety with fainting, resulting in hyperventilating, which is going to increase the risk for fainting, the SSRIs may be helpful for that. Finally, initial orthostatic hypotension. So we talked about first stand up, your blood pressure is going to go down, heart rate's going to go up. In the instance of initial orthostatic hypotension, you're going to have a blood pressure drop of around 30% in the first 10 to 15 seconds, and that's going to come back to normal typically within 30 seconds, but that cerebral perfusion may take a little bit longer for the lightheadedness to clear. Syncope is possible, but it doesn't often happen. It's just the biggest complaint is dizziness with standing. This is not a pathologic condition, but it is made worse by acute illness, lack of physical activity, low fluid intake, high caffeine, basically teenager life. If you want to measure it, true orthostatic hypotension is a greater than 20-point drop in systolic blood pressure and a greater than 10 in diastolic after 3 minutes of standing, and that's true, acute or chronic orthostatic hypotension as opposed to initial orthostatic hypotension. If we want to do these vital signs, sitting I have no use for. The active standing test is to do them after supine for several minutes, repeated at 1 minute of standing to assess for initial orthostatic hypotension, and then after 5 minutes of standing to assess for resolution. The take-home points: most syncopal episodes are due to neurally mediated syncope. It's a benign and self-limited condition. If they have lack of prodrome symptoms with an abnormal exam and a scary family history, we probably should see them. But most vasovagal syncope can be treated with lifestyle changes and positional training. And the only medication that has been shown in randomized trials to be helpful is midodrine. All right, thank you for coming to my TED